I'm Thomas Baldrick with coverage of ASH 2015 in Orlando, joined now by Dr. Rami Komrokji from the Moffitt Cancer Center in Tampa. Thank you, sir, for stopping by.
Thank you.
Let's talk about one of your studies. Somatic gene mutations serve as molecular biomarkers predictive for response to immunosuppressive therapy in MDS. What was the purpose of this study?
So obviously immunosuppressive therapy is an option that we think of for lower risk MDS. However, actually this option is underutilized. It's usually limited to be used at academic centers, and often a small subset of patients who are younger than 60 would get that treatment. Although there had been studies before reporting that durable responses improving blood counts in more than one cell line can be obtained with that treatment. So our goal was to try to look at our experience to try to see can we maximize the benefit, expand the patient population that can benefit from this treatment, and then obviously now, since we've learned more about the disease and the biology, take it to the next level and see if there is any somatic molecular mutations that would predict the outcome. So basically that will allow this treatment to be available for a larger population of patients.
Why do you think it was underutilized?
Well, there are different reasons. First, the treatment is inpatient-based, so not all the centers offer it. Typically, immunosuppressive therapy with ATG cyclosporin is offered for aplastic anemia. The data in myelodysplastic syndrome, some centers believe that the treatment is only for a subset of patients that have a type of MDS called hypoplastic, where the bone marrow is empty, while the multivariable analysis from the NIH study suggested that is not the most important factor. The most important predictors of response by the NIH study were age, below age of 60. And as you know, MDS patients, most of them are above age of 60. The median age of that disease is somewhere between 67 to 70. So that's why a small subset. And also there is some unawareness about the option of treatment and the potential responses in the community practice.
So what finding in the study showed a benefit of response?
Right. So we took two parts. So first we looked at the clinical predictors, what's been published, and tried to look into that in our experience. So we had almost 66 patients that were treated. We looked at the responses, and the responses in this case are hematological improvement, so a blood count improvement. And I have to say that those are what we call a lower risk MDS population. So those are patients that don't have increased blasts, don't have bad cytogenetics. Usually we use a system called International Prognostic Scoring System, and those are patients are low or intermediate 1 risk. So we looked at almost 66 patients in that category. Overall, almost around 40% or so had a response. So we looked at factors that we've known, like age. In our experience, age per se did not matter. We looked at the things like hypocellularity, all the factors that are known clinically. And what we noticed that basically patients, there was a little bit slight more responses if patients got equine ATG versus a rabbit ATG, if patients got combination of the ATG plus cyclosporin. If patient had a higher risk disease by the new revised IPSS, those patients did not respond. And then we also noted that many patients would have responded if they got the treatment earlier in the course of the disease. They would have less chance of response if they got azacitidine. And then we also looked at a model that was developed by the NIH, looking at age of the patient, the duration of red blood cell transfusion, and a marker called HLA-DR15. In our experience, in those 66 patients, we did not see that model really predicted much the response. So the baseline on the clinical, or the summary of the clinical variables was basically the combination therapy, ATG cyclosporin, early use in the disease, not using it after azacitidine were the signals that we saw in our group. Then we had material available to do a somatic gene mutation panel of 49 genes known to occur in myeloid diseases in almost 40 patients. And I think we identified abnormality in almost 50% of those patients. And basically a presence of a mutation, had slightly less chance of response, but particularly those patients that have a mutation called SF3B1, which is a splicing machinery mutation that correlates with the type of MDS, we call it refractory anemia with ring sideroblast, had much less chance of response. Actually, 1 out of 9 patients only responded. The other thing we noted is basically the patient that had mutations, even if they responded, they had a shorter duration of response. And those patients that had mutation, in general, there was slightly higher risk of going to leukemia. So our conclusion, based on what we've seen, that still some patients with mutations could respond, but I think particularly patients that have the SF3B1 mutation may not benefit from this treatment. There are other exciting treatments coming for that special subset of patients that they probably should go on clinical trials.
What stands out to you most from what you found with these 66 patients, and where does it lead you next?
Right, so as I mentioned, I think what stands out that there are certain clinical things that can predict response, that following the biology of the disease, using such treatment should be early on in the disease. And from the molecular mutation data, I think this suggests that if a patient has a SF3B1 mutation, the chances are low to respond. Obviously, whenever you try to predict response or develop biomarkers for response, they have to be validated in an external cohort. So I think the next logical step will be validating this with some of our colleagues in other centers, see if what we saw in our group of patients can be seen in other groups. And if that's the case, then as I mentioned, I think if patients have like those splicing machinery mutation like SF3B1, those are not likely to benefit. On the other hand, patients that are early in the disease, don't have bad risk features, this is a treatment that physicians should think of, especially that we only have limited options for treatment for patients who have lower risk MDS.
We wish you luck with the doctor going forward. Thanks for spending some time with us.
Thank you.